Hello everyone and welcome to this webinar entitled Swallow Screening, Sensitivity, Specificity, and How Many Swallows Need to be Observed. My name is Professor Steele and I will be your speaker for this webinar. This is a recording of a talk that I delivered at the ASHA Convention in November 2019 in Orlando. And before going further, I do have a few disclosures as shown on the slide. There is a handout for this webinar which you can download at the address shown on the screen. So I'm assuming that you're listening to this webinar today because you, like me, are interested in this problem that we call dysphagia. And I think an important place for us to start is by taking just a moment to think about our definitions of the word dysphagia. For me, I will acknowledge that as a clinician who works primarily in the area of oropharyngeal dysphagia, my definition is heavily pharyngeal in its focus. But for me, the problem of dysphagia is a major syndrome. It's something that can occur at any time across the lifespan, and it may be characterized by any of the three bullets shown on this slide. First of all, it may be characterized by a patient reporting that they experience difficulty swallowing. But this is not necessarily required, and we all have had patients who are unaware of their swallowing impairment. I think for me the core of my definition is that dysphagia involves an impairment either in the ability to protect the airway during swallowing or in the ability to transport food or liquid efficiently through the pharynx and into the esophagus. And if your definition of dysphagia is similar, then I imagine that you, like me, understand that we're worried about dysphagia because we believe from the literature that there's an association between impaired swallowing safety and the development of respiratory consequences, including pneumonia. We also understand that impaired swallowing efficiency can contribute to a risk of dehydration and/or malnutrition. And of course, it's important always to remember that dysphagia also has an impact on people's quality of life, and that either dysphagia itself or some of the management strategies that we recommend as clinicians can lead to restrictions in participation in social eating activities and thereby have a negative impact on people's quality of life. This slide lists the different stages in dysphagia management that we may go through as clinicians working with our patients. And this list actually comes from the preferred practice guidelines that exist in my home province of Ontario in Canada. According to that practice standards and guidelines document, the process of working with a patient with dysphagia often begins with screening or detection of a problem in the first place, and this is going to be the focus of our webinar today. So the remainder of this webinar comes with a warning or a caveat that some of the things I say may make you feel uncomfortable. The truth is that I'm going to take you on a journey through the doubts and questions that I have as a clinician and as a scientist, and I hope that this is helpful for you in critically thinking about swallow screening. Swallow screening has been a very hot topic in our literature for the last 10 to 15 years, but the truth is that none of us has yet developed a perfect screening approach. So as we explore the strengths and weaknesses of specific screening tools, I hope that you will remember that my comments are made in the spirit of critical thinking, and they are by no means intended to single out the inventors of those approaches for criticism. Many of you, I'm sure, already work in facilities where there is an existing swallow screening process in place. But just as I challenged you a few minutes ago to think about your personal definition of dysphagia, I want to provocatively challenge you on this slide to think through your definition of screening and perhaps of the ideal screening. What in your definition should a screening include, and what should it exclude? Who should perform it, and does it matter who performs it in terms of the information that is obtained? in your screening process that's either in place or in your ideal, is the process intended to identify aspiration? Or is it intended to identify something a bit more general related to your definition of dysphagia that we discussed a few minutes ago? And are the tasks that are included in that screening good ones for identifying these things that you're interested in finding? And finally, what's supposed to happen when the screening identifies a concern in a patient? Throughout this presentation, I'm likely to use the words pass and fail to describe the situation where a person either doesn't or does show a sign of concern in a screening. Although I don't like the words pass or fail, particularly when it comes to thinking about instrumental swallowing assessments, these are words that are widely used in the screening literature, and so I'm likely to adopt that convention throughout the webinar. As a scientist, I've been privileged to travel to many countries around the world to meet with dysphagia clinicians. And one of the things that I found interesting in those travels is to realize that the concept of screening is not the same everywhere in the world. And in fact, in some languages, there's really no distinction between what we might call a screening or a full assessment. So I think it's helpful just for a moment to take a look at definitions of screening, such as the one here from the World Health Organization. And they define a screening as the presumptive identification of an unrecognized disease in an apparently healthy, asymptomatic population by means of tests, examinations, or other procedures that can be applied rapidly and easily to the target population. So as we talk through screening, I think it's important for us to ask ourselves whether our swallow screenings fit with this definition, particularly when it comes to constructs such as rapid administration and easy interpretation. In clinical medicine, whenever a person fails a screening test or shows a sign of concern on that screening, then the general expectation is that that person will then be triaged and referred for a more detailed assessment. It's important to recognize that a screening does not provide enough information to guide the intervention in those who test positive. Common examples of screening that you may be familiar with outside the context of swallowing would include mammograms for women to detect preliminary signs of breast cancer, or perhaps prostate cancer screening in men. And it's interesting to note that some of these tests may perform better than others. So you'll be familiar with the controversy that mammography does not always accurately detect a tumor in a woman who does have breast cancer, and likewise prostate cancer screening blood tests do not always perform well in identifying the concern. So over the past 10 to 15 years, many best practice guidelines around the world have recommended that swallow screening should be routinely adopted in individuals with new strokes. And you can see here one example of that in our Canadian Stroke Network recommendation. But even though swallow screening has been strongly recommended and advised in best practice guidelines in Canada for many years, you can see here that an audit by the Canadian Stroke Network showed that we still weren't performing all that well in actually doing these screenings, or at least not in documenting. And they voiced a concern in this document that the rate of screening was suboptimal. And you can see here also that they point to aspiration pneumonia being an assumed consequence with a rate of 5.7%. And they're hoping that by implementing swallow screens, this number might go down over time. Here on the slide, I'm listing some other desirable characteristics of screening tools and their use. First, you can see that we want a screening approach to be accurate in identifying the presence or absence of the problem of interest. And really, this is the crux of the matter. And when we look at performance of screening, it will be this accuracy in detection of a problem or of the absence of a problem that we will be scrutinizing. A screening process is also not intended to be a full assessment, and so it's intended to be quick and easy to implement. In fact, in many jurisdictions, a screening is thought to be something that should not require a special professional skill set and can indeed be performed by a variety of different healthcare professionals following training. This is a topic we'll come back to later in the presentation because I'm aware, based on recent social media discussions, that there are places in the United States in particular where speech pathologists are doing swallow screening, and I will want to challenge you to think about whether it's reasonable to expect that a speech pathologist and a different healthcare professional, perhaps such as a nurse, will indeed see the same things in a swallow screening protocol. As mentioned a few minutes ago, a screening is intended to identify people who require referral for more detailed assessment, and it should not ever be considered to provide enough information to guide treatment. Another thing to think about in terms of screening is that most of the screening work that we read about in the literature has been explored in specific populations, with stroke being the most common. And so if you were to ask the developer of a screening tool that has been developed for stroke and validated in stroke, whether this screening tool has value for identifying dysphagia or aspiration in a different population, perhaps in cardiac patients, then the correct answer should be that the test hasn't been validated in that different population, and therefore caution should be used. When we look at the swallowing literature to ask whether dysphagia screening works, it's important to realize that the majority of the literature focuses exclusively on screening for aspiration. There are a few screening tools that claim to look more generally for dysphagia, but I will argue later that the kinds of tasks that are included in those screening tools are heavily focused on issues related to airway protection, and they're primarily looking for signs of airway invasion, such as coughs or throat clears or wet voice. And so I would propose to you that really the majority of our screening literature focuses on screening for aspiration. A limitation of our literature is that the majority of these tests have been studied in stroke only, although there are a couple that have looked more generally. And in terms of understanding the literature, the accuracy of screening has usually been explored in one of two ways. The majority of evaluations of screening have compared the results of the screening to a reference test that has been a subsequent instrumental examination, or at minimum an instrumental examination performed separately from the screening test itself. And so we're there looking at the results of one test compared to the results of another test. But another way that screening has been evaluated in the literature is by looking at ultimate health status consequences over time in hospitals or facilities that have adopted screening compared to facilities that haven't. And here the consequences that have been looked at are things like pneumonia rates, length of stay, and ultimate survival. One study of this type is shown here from Dr. Judith Hinchey, published in the journal Stroke in 2005, and this is a widely cited study. What the investigators did in this study was that they took 15 hospitals where stroke patients were seen, and these were similar hospitals in terms of the stroke severity profile. In 6 of these hospitals, there was a formal dysphagia screening in place. They weren't necessarily all using exactly the same screening protocol, but the screening involved some sort of checklist and a swallowing challenge in the form of water swallows. The remaining hospitals were not using a formal swallow screening protocol, and this allowed for comparison of outcomes between these two different types of hospitals. You can see that in the hospitals where a formal process was in place, that adherence was still modest, about 3/4 of the time were these screenings being used, and the study cites that pneumonia rate in these hospitals was 2.4%. In the other hospitals, there were sort of informal screenings going on about half of the time, but less than in those with a formal protocol. And the statistically significant finding that's reported in this article was that the pneumonia rate was higher in the hospitals that didn't have a formal screening process. One interesting finding that one can take away from the Hinchey study is that perhaps it's less important what the specific tasks of the screening are than whether or not there is a formal expectation of doing some sort of screening in a systematic way. But I think it's important for us to stop for a moment and remember that screening in itself is not an intervention, and that the outcomes of screening ultimately depend on the things that follow that failed screening result. And typically, these would include a more detailed swallowing assessment, perhaps beginning with a clinical bedside, and followed by an instrumental assessment where there are questions that can't be answered without the eyes of instrumentation. And also, critically, some sort of management plan is recommended by the clinician. So given that screening isn't an intervention by itself, it's perhaps not fair to look at pneumonia rates in those who fail screening versus pass screening and conclude anything about the effectiveness of the screen itself. This article that's shown here on the slide is a recent paper out of Dr. Rosemary Martino's lab in Toronto, and if you look down these forest plots, you can see at the bottom of each one there's a red dot on the screen. And what that dot shows is the incidence of the particular thing that's being looked at, either pneumonia or severe disability or discharge, in people who fail swallow screening. And because the dots are to the far right of the midline in each of these plots, we're seeing a much higher odds that a person who fails the screen will end up with one of these consequences. So you could look at this and walk away from this thinking failing swallowing screening is a really bad idea because you're more likely to get pneumonia or end up with severe disability or end up in long-term care. So here, we're not saying that the screening itself contributed to these findings, but we're saying that people who fail screening have really severe dysphagia and are more likely to have consequences. And what we would hope is that ultimately we would evaluate the interventions that are recommended following a failed swallow screen to see if they can shift these red dots on the plot further back to the left towards the midline and reduce the complications of dysphagia. So I mentioned earlier that swallow screening has been a hotly debated topic in our literature for at least a decade. And there are, in fact, a very large number of reviews that have looked at swallow screening and its effectiveness. And this article here on the slide is just one of those articles from Stephanie Daniels' group, where they talk about the differences in protocol that we have and the fact that we haven't yet managed to agree on the same tasks across screening protocols that we believe really hold the magic, if you will, for correctly identifying dysphagia problem in a patient. In fact, if you dig into the available swallow screening tools that are described in the literature, there are far more commonalities than there are differences in the specific tasks that are used. Most swallow screens include an evaluation of readiness on the part of the patient to begin oral intake and even to perform the screening test. This commonly includes observation of their alertness and their ability to sit upright and follow instructions. These readiness criteria may also make comments on the person's breathing, such as whether they are requiring supplemental oxygen or breathing room air by themselves, and also observations regarding secretion management and drooling. And for you as clinicians, one thing that's important to comment on here is that when we go into a research project to evaluate a screening tool, it's possible that some of the people who fail the screening in the research study may fail right here on the readiness criteria, and they're still included as a general rule in the study. Once the readiness criteria have been documented, then it's very common for swallow screenings to include some sort of evaluation of non-swallowing tasks. This section often looks like a mini oral mechanism exam or a mini clinical bedside swallowing assessment. There are still some screening tools that document whether there is a present or absent gag reflex, even though most of us don't feel that the gag reflex really tells us something valid about the person's swallowing ability. Commonly, these non-swallowing tasks will involve some sort of evaluation of oral motor function, most often an evaluation of tongue movement. And then there are commonly documentation of the person's speech, and in particular whether they have dysarthria. Finally, this section often includes the elicitation of a voluntary cough and some sort of comment on the person's voice quality before any swallowing tasks have been performed. And as with the readiness criteria, it's important to realize that in the research, where people have been going through a standardized swallow screening process, some portion of the people who have failed in that study will have failed during this non-swallowing task section, and they may never have reached the point where actual swallows are observed. Finally, as shown on the right of the slide, there are very commonly swallowing tasks included in these swallow screening tools. And here the differences start to emerge in terms of the stimuli that are investigated. But by and large, the questions that we expect the screening professional to be looking for all relate to questions of airway invasion and possible penetration and aspiration. Here we ask, was there a swallow? So did you see or feel laryngeal elevation? Was there a cough or a throat clear after the swallow? Was there a change in voice quality after the swallow, or perhaps a change in breathing? So it's in these swallowing tasks where we see the differences emerging between the different swallow screening protocols that are in common use today. And I think this provides an opportunity for us to stop and think about whether we think the differences that we see matter and what the best tasks are for answering our questions about a person's swallowing. If we look at the different stimuli, we see differences across protocol in the number of boluses that are used. So we have some screening tools that use several sips of water, either naturally sized sips or measured sips, such as 5 milliliter sips. And here, for example, the Torbest test developed by Dr. Martino uses 10 5 milliliter boluses. There are some protocols where we see a whole number of different tasks, really looking like a clinical bedside swallowing examination, not just limited to water, but a whole bunch of different stimuli. And an example here would be the GOOSE, the Gugging Swallow Screen, that has been developed in Austria and is quite commonly cited in the literature, in which there are 17 different tasks included, ranging from thin right up to a solid bolus. The sequence of stimuli may also differ across screening protocols. So, for example, some screening tools may start with water and move thicker, But other screening tasks may begin with a thicker consistency. Two examples here would be the screening test for acquired neurogenic dysphagia, the STAND, which starts with applesauce as a stimulus, or the volume viscosity swallowing test developed by Dr. Perry Clavé in Spain, which begins with nectar thick liquids and then moves either thicker or thinner depending on the signs that are seen. And then we have volume differences, as mentioned. We might have several boluses of the same volume, or we might have repeated boluses where the volume increases. That's a feature of some of the screening work described by Dr. Stephanie Daniels, and also of the volume viscosity swallowing test. And finally, of course, there is the 3-ounce water swallow test, or the 90 cc swallow test. That is a core component of the Yale swallow protocol, where the challenge is a single 90 milliliter liquid challenge, with the patient being instructed to drink the entire 90 cc's without stopping. Another place where screening tools differ in the literature is with respect to the reference standards that are used in validation studies. That is, whether the screening results are compared to speech-language pathologist findings on a subsequent clinical bedside swallowing task, or to an instrumental exam. And here we have examples both of endoscopy and of video fluoroscopy used to collect the truth of the patient's swallowing status. This slide shows you a summary of some of the popular screening tools that I've just mentioned, and you can see here some of the variations in their tasks and also in the reference tests that were used. Starting here with the standardized swallowing assessment, first described by Dr. Lynn Perry in the United Kingdom. You can see here we have 3 5 cc water swallows followed by a half glass of water, and the reference test here that was used is speech-language pathologist opinion on a clinical bedside swallowing test. Now, although the standardized swallowing assessment is quite widely used, and it also goes under the name the ASSIST in Australia, we do need to recognize that a clinical bedside swallowing examination suffers from the same limitations as the screen with respect to being able to see silent aspiration, and so it's really not today considered ideal to use a clinical bedside swallowing reference test for validation of a screen. I've mentioned the test developed by Dr. Stephanie Daniels, where she used 3 different volumes of water, each presented twice, and the validation here was done by video fluoroscopy. I've also mentioned Dr. Clavé's volume viscosity swallowing test and Dr. Martino's Torbes test. You can see here that the tasks are quite different, but both of them used video fluoroscopy for validation. And finally, at the bottom of the screen, we see the Gögging swallow screen developed by Michaela Trappel in Austria, as mentioned, 17 different tasks, and the validation done by a FEES exam on the same day. And also the Yale swallow protocol developed by Dr. Stephen Leader and Dr. Deborah Suter, where, as mentioned, the task is to drink all the contents of a 3-ounce cup of water without stopping, and the validation was done with FEES exams. When you read a study where the accuracy and validity of a swallow screening result has been reported, you're going to encounter some of the test terms that are seen here on the screen, and I find this chart extremely helpful as a reference to remind myself what these parameters are measuring. The most common statistic you're going to read about is sensitivity. This looks at the number of people who fail the exam as a proportion of the people who have a true underlying problem. So if we think of aspiration as the target here, of those people who showed aspiration in the reference test on a video fluoroscopy or a FEES exam, for example, how many of them showed a sign of concern on the screening that flagged the possibility that they would be a person who has penetration or aspiration? That's the sensitivity target, and we generally expect that to be high. Specificity is another term you'll read in the literature, and this is related to sensitivity, but it's not strictly the opposite. So here we're asking of the people who really don't have the underlying problem, what portion of them passed the test and didn't show a problem? And then finally, there's an important statistic called negative predictive value, and this looks at a slightly different ratio. Here we're asking of all of the people who passed the test and didn't show a problem, what proportion of them genuinely didn't have the problem of concern? So you might be wondering, how good should these tests be when we evaluate them in a validation study? And for screening, generally speaking, the goal is to have high sensitivity, that is high accuracy in detecting people who have an underlying problem. And usually you'll read that we're looking for 80% detection or better. That means we might miss 2 out of every 10 people who really have the underlying problem, but generally speaking, 80% is the lower target. This target might be different depending on population. So if you're dealing with a group of people who have respiratory fragility, then you might want to be more confident and be looking for 90%. Whereas if you're looking in a population that isn't as acutely ill, then perhaps you're okay with a lower performance on sensitivity. It's much less clear whether there's a sort of accepted threshold of how good the specificity of a swallow screening test should be. Indeed, some people would argue that they're not worried about specificity in screening because specificity will be worked out in the next step of assessment. But here we're talking again about the proportion of people who do not have an underlying problem, who are correctly identified as not showing a problem on the screen. It's not as critical, but the consequence of having low specificity is that we over-identify the problem. And in the world of dysphagia, in some places, this can have some quite serious consequences for the patient. They may be made NPO and not allowed to have oral intake until they have their instrumental swallowing examination, and that wait could be quite long. So clearly we want to avoid doing that if we can. And it may also be that they're put on thickened liquids or some sort of texture-modified diet on the presumption of a problem being present, and that could go on for some time until the verification test is performed. So this is a sort of balance that needs to be struck, and I would personally suggest that at least 60% specificity is a desirable target for swallow screening. Negative predictive value is not as commonly reported as specificity and sensitivity in our literature, but it's actually a very interesting parameter. And again, like sensitivity, we want negative predictive value to be as high as possible. Here we're talking about the proportion of people who pass the test who genuinely don't have an underlying problem. So these are true negative findings from the screen. And of course, if you have high negative predictive value, what it means is that you can trust that negative result. And with high negative predictive value, you can be quite confident about allowing people who've passed the test to go on to eat a normal diet without further swallowing assessment. And this high negative predictive value is actually a characteristic of the Yale Swallow Protocol, and you may be familiar with some of their literature, but they've shown in several studies this characteristic that the negative result is trustable, that people who have passed the Yale Swallow Protocol, who've then gone on to receive regular diets, have not had adverse events during the time that they've been monitored. But as we think about the performance of the different swallow screening protocols on those metrics of sensitivity, specificity, and negative predictive value, I think it's important for us to pause and think about some issues that may exist in these reported results. The first I've alluded to already in the talk is the difference between screening for aspiration or screening more generally for dysphagia. And you should pay close attention when you're reading these studies to understand what it is that the investigators claimed to be screening for. Screening for aspiration is a more precise measure than screening more generally for dysphagia. So there are a number of different things that could show up in the validation test that might meet with the accepted definition in that study of dysphagia that are being used as the comparison for the things that showed up in the screening. And some of those associations may be more plausible than others, and I'll show you this in a moment. Another limitation in our screening literature is the issue of time differences and lags between collection of the screening result and collection of the validation test result. And in some of the literature, those time lags can be quite long. And this really brings up the question about whether it's reasonable to expect that the patient has remained stable across those two tests and is likely to look the same in test A and in test B. Similarly, when you look at this literature, it becomes clear that the reference tests that are used for validation are much more comprehensive tests than the screen itself. That's almost by definition something that you would expect. However, what this means is that perhaps the screen has a different likelihood of catching the problem than the much more comprehensive swallowing assessment. And so you have to stop and ask yourself whether you think that is a problem in terms of the validation. And finally, a problem that I will take you through is the issue of whether we look at results for each individual bolus or task that's performed in a screen and in a reference test, and how we summarize that information to get a net result at the participant level for the screen versus the validation study. So I want to dig into a few of these challenges regarding the performance characteristics of swallow screening tools with you, beginning with this question about how plausible is it that the things we see in screening are really indicating dysphagia. And here as one example, I'm going to take you through some of the results reported by Stephanie Daniels, who was looking at the performance of a screening protocol in stroke patients. And here she used a video fluoroscopy for validation of the screening result, and the definition of having a problem on that video fluoroscopy was a single occurrence or more of a penetration aspiration scale score of 3 or worse, that is penetration or worse, across 11 different tasks. And it's important to note that that video fluoroscopy was performed within 48 hours of screening. So let's start by looking at the non-swallowing components of the screening test that Stephanie evaluated. And here we have potentially abnormal signs noted on a volitional cough, on a gag reflex test, an evaluation of voice quality, so just a binary description that the person had dysphonia or didn't, and of dysarthria. And on the far right, you can see the sensitivity and specificity results for each of these signs compared against the presence of penetration or aspiration on the video fluoroscopy. So you can see that a voluntary cough, when abnormal, didn't have good sensitivity for predicting that penetration result. It had pretty good specificity of 85% for ruling out a problem of penetration or worse. The presence of an abnormal gag reflex really had modest performance on both statistics, and dysphonia had also modest, a little bit better performance, 73% for both. So the best performing non-swallowing task in this screening protocol for detecting or predicting that a person would penetrate on the video fluoroscopy was in fact the observation that they had dysarthria. And that really might not surprise us terribly, because people with stroke who have dysphagia may also have dysarthria. And you can see that for people where dysarthria was noted, that there was an 85% sensitivity for predicting that they would also show penetration or worse on their video fluoroscopies. But let's go on to look at whether the swallowing trials in the Daniels protocol did better than the non-swallowing tasks. And this is where I think the questions of plausibility really start to come up, because here you can see that the protocol involved 6 boluses of water of different volumes, and the abnormal signs that they were looking for were change in voice quality or a cough after the swallow. And you can see that the cough only had a sensitivity of 54%, and the voice change sign was lower than that. So these observations in this study cohort were not strong predictors of the truth with respect to the presence of penetration or worse on the video fluoroscopy. And I think it's of some concern that these signs that are very much valued in our clinical practice as signs that we interpret to suggest that there may have been an airway invasion problem actually performed worse than simply observing whether a person had dysarthria. In subsequent research, Dr. Daniels was actually able to identify slightly better sensitivity for the single sign of a cough for predicting penetration and aspiration with a value of 65%, as shown in this table. And you'll see that she also did something really interesting where she calculated the sensitivity and specificity of looking for 2 signs of concern on the screening test rather than just 1, and that dramatically improved the sensitivity to 92%, although the specificity fell down to 64%. The remaining examples in this table are all screening tests where the validation study involved an instrumental exam, although the endpoints were not all the same. So some of them were looking for penetration and aspiration on that instrumental test, and others were looking for dysphagia more globally. It's important to recognize that in all of these tests, the instrumental exam was performed at a different time than the screening test itself. Another thing to note about these studies is that in all cases, the tasks that were included in the screen were different than the tasks that were included in the subsequent instrumental reference test. But when we look at how they reported the performance of the screen, what is done in these studies is that they take the net result of the screen, that is, was there 1 problem, or as in the case of the Daniels test, were there 2 problems, and they compare that to the net result of the instrumental test. Was there 1 problem on the instrumental test that demonstrated the issue of concern, whether that be penetration, aspiration, or dysphagia? And so when you do this, where you have a different number of tasks involved in the screen from the reference test, but you're rolling the results up to a net result from test A to test B, it turns out that there's actually a much higher chance of correspondence than 50% chance. This has the effect of inflating the sensitivity that's reported and decreasing the specificity and the negative predictive value. To explain this challenge regarding the performance of swallow screening tools, I want to take you through the exercise that's shown here. So imagine that on the left we have a screening test that includes 3 sips, and the person has a problem on the 3rd sip. So let's imagine that the apples are safe swallows and the orange is a swallow on which there was penetration and aspiration. And then on the right, we have a reference test, and again we have 3 sips, and on the 3rd of those, the person has a problem. So it would be reasonable to look at those 3 swallows and ask which one of them is a problem, which one of them is an orange, and we would see on the screen that it's bolus number 3, and as illustrated on this slide, we would see on the reference test that it's also bolus number 3. And so that's kind of interesting. It's the 3rd bolus in both tests, even though they're performed at different points in time. But that's not what the validation studies in our literature tend to do. Rather, what they tend to do is ask the question shown at the bottom of the slide, which is they roll up the results to a participant net result across the 3 swallows in the screen test. And they ask, is any one of these a problem? Is any one of these items an orange? And of course the answer is yes. And they would do the same for the reference test on the right. Is any one of those an orange? And the answer would be yes. And so we have correspondence. But I hope you can see that we could have the same result even if the orange was in a different position in one of those tests. Perhaps it was the first swallow on the screen and the 3rd swallow on the video fluoroscopy. And yet the 2 tests would still be determined to have perfect correspondence when rolled up to the net result. Now, correspondence or a lack of correspondence in the details of the screening test versus the reference test may or may not be a big problem. But I want to take you through 2 scenarios so that you can think through this and decide whether or not this is something that would be a concern for you as a clinician. So on this first scenario here, I've mocked up a potential scenario for a person on the left who's undergoing a swallow screening test that looks very like the Torbest test developed by Dr. Rosemary Martino. Here we have the person showing no signs of concern on the readiness criteria and the initial non-swallowing tasks. And then we get to the 10 boluses of water. And let's imagine that on this particular day, this particular patient showed no signs of concern on the first water bolus or on the second water bolus. But on the 3rd water bolus, they started coughing, and the clinician who was performing the screening test appropriately decided to terminate the test and document a result of fail, referring the patient, therefore, for more detailed testing. So let's imagine on the right that we have this same patient and they've been referred, and we're going to do a video fluoroscopy using the MBS-IMP protocol. And let's, for the sake of the exercise, imagine that this is the same day, just later in the day, that the patient is undergoing this test. And as you may know, in the MBS-IMP protocol, the test begins with 2 teaspoon-sized volumes of thin liquid barium, and the first of those is usually discounted and considered to be something where a problem is forgiven, if you will. So let's imagine that this patient did in fact show a problem on that very first thin liquid bolus, but that bolus is not considered as part of summarizing their impairment on the MBS-IMP. If it were, that would be a correspondence with the single fail result on the screen, but according to the MBS-IMP protocol, it isn't. So then they go on to a second thin bolus, and this time they do just fine, and they also do just fine on the thin cup sip. But it's only when they get to the task that is quite often the one that demonstrates impairment on swallowing safety on the MBS-IMP, and that is the sequential thin drinking with a large volume, that they show a problem with penetration and aspiration. They then actually continue with the rest of the protocol and show no signs of penetration and aspiration on the remainder of the MBS-IMP protocol. So here at a net result level, we have agreement between these 2 tests. We have a failed screen based on a cough on a single bolus of water, and we have confirmation of penetration and aspiration on the MBS-IMP protocol. On thin liquid, it's the same type of stimulus, but not on the same volume, although that first ignored 5 cc volume would in fact have met that criterion. I'm not personally too disturbed by the differences between these 2 tests because they both ultimately showed a problem, and I think that they also both showed some degree of safe swallowing, so they're not too discrepant, although the results are not precisely the same. But let's imagine a second scenario that might cause you a little bit more reason to think. So here, let's imagine that we are doing a swallow screening where there are 6 boluses of water. And let's just imagine that we have magic X-ray eyes and we can actually see the truth on those very same swallows without waiting for the reference test to be performed at a separate point in time. Let's imagine that the first 3 boluses of water are swallowed without any sign of difficulty, but on the 4th bolus, the person does display some sign of penetration or aspiration outwardly, like a cough or a throat clear. And let's imagine that the protocol continues even though they show that sign, and the next 2 boluses are fine. So we have a net result of a concern, a fail, on those swallow screening tasks that would prompt a referral. But if we had those X-ray eyes and we could know the truth of what actually happened in this patient, let's consider that perhaps the first result was true. There was no outward sign of a problem and they showed no penetration or aspiration on that swallow. But on bolus number 2, although they showed no outward signs of concern, the truth was that they had a silent aspiration event. Let's imagine then that the remaining 4 boluses in this swallow screening protocol, in truth, showed no airway invasion. They were completely safe swallows, even though on bolus number 4 the person coughed. So here we have a situation of mismatch between the swallow screen and the underlying truth for those very same swallows, and yet the net result of both exams would agree that there was impairment. The question is whether it's a problem for you that in fact the swallow screen had 2 incorrect results. That is, the pass result for the 2nd bolus was inaccurate and the fail result for the 4th bolus was inaccurate. You may not have a problem with this because of the ultimate net result reporting, or it may be something that causes you to stop and think about the likelihood that a swallow screen could in fact have details embedded in it that are inaccurate, even though the overall result appears accurate. Another thing that is embedded in that example of inaccurate results is a challenge regarding the reported sensitivity of the screening tests that we read about in the literature. We know that some portion of our patients actually have silent aspiration with no outward signs that would be detected in a swallow screen. And if that's true, then a sensitivity of 100% should be impossible. So with those 2 scenarios that I've given you that might challenge the way you think about the accuracy of swallow screening observations, I'd now like to take us through a scenario in real life where we watch videos of patients performing a swallow screening protocol for which we also happen to have the simultaneous video fluoroscopy truth. These examples come from a research study that we performed about a decade ago, where what we did was we set up a video camera to take a movie of the patient's face and record any sound that was produced so that it mimicked the situation that a nurse or another healthcare professional would see during a swallow screen. But we happened to do this study in video fluoroscopy, and so we were able to capture the truth regarding the safety or efficiency of those swallows for every swallow performed. And rather than swallowing water, these patients swallowed thin liquid barium. And we were directly comparing the information gleaned from the video to the truth of the video fluoroscopy scored by raters after the fact. So today I've got 2 different examples to take you through, and what you'll see in both cases are that the patient will first perform a baseline tongue lateralization task. They're then going to perform a baseline phonation task. Now, at the time that we did the study, we borrowed this task from a screening protocol that was being discussed in the literature called the Massachusetts General Hospital Swallow Screen, and they had chosen the phonation task ha 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 rather than a sustained ah or any other kind of phonation task. And we thought at the time that this was an interesting choice. We were particularly interested in the fact that phonation would start and stop several times during this task, and we thought that perhaps if material was sitting on the vocal folds or near the vocal folds, that situation of starting and stopping phonation might be likely to trigger a cough if there was material on the airway, and so we went with that task. With hindsight, I don't think it was a great task because it led to unusual interpretations on the parts of the patients. They were confused by the task and thought perhaps we were asking them to laugh. And so if I were redoing this, I would probably choose a different phonation task. The third thing you'll see is a baseline voluntary cough. So these are the 3 non-swallowing tasks that were included in the protocol. We'll then pause the videos and reflect on what we've seen there, and then we'll move on to a sequence where the patients are given 3 teaspoon-sized boluses of thin liquid barium. And after each of those boluses, we asked them to repeat the phonation task so that we could listen to the voice and see if we heard any signs of change in voice quality. So what I'm actually going to suggest that you do as you watch these videos is to put yourselves in the shoes of a nurse and imagine that rather than being a speech-language pathologist, you're a nurse and you work in an emergency room and you've been asked to perform this swallow screen to see if you see signs that should trigger a referral to speech-language pathologist for a swallowing assessment. And we'll come back to this challenge of trying to imagine what a nurse would see as we watch the videos. I should also add before we watch these videos that these were individuals who were enrolled in the research study who were already going for a video fluoroscopic swallowing test. So there was a reason to imagine that they might have dysphagia. So it's a biased sample, if you will, of patients for whom a video fluoroscopy was a reasonable thing to do. And they are largely neurogenic in their etiology. I don't have the specifics for these 2 patients, but they are more heterogeneous than stroke per se. So let's begin by watching the non-swallowing tasks in this first patient. So we've just seen tongue lateralization, a voluntary cough, and the baseline phonation task of ha 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 ha. Now, as speech-language pathologists, we might notice all sorts of things about this patient, such as issues with facial muscle tone or asymmetry. But those aren't questions that we are asking the nurses to take note of. We're asking them instead whether they saw any problems in the course of the 3 tasks that were performed. And so I would suggest to you that as you watch that the patient was able to lateralize their tongue from side to side with no apparent difficulty. They also produced a cough with good glottal contact, and they produced the ha 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 with no really audible dysphonia or difficulties with voice quality. And so based on this information so far, I think it's reasonable to suggest that this patient has so far shown no signs of concern and passed the non-swallowing components of this swallow screening protocol. So let's now move on to watch the 3 teaspoons of thin liquid barium, each followed by the phonation task.
ha 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 ha. Ha 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 ha. Ha 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 ha.
So here it's very clear that this patient had a coughing episode after the third of those 3 boluses. And there was also a small cough after the first bolus. And so if we're going by the instructions that are given to the nurse, we certainly hope that a nurse who was observing this in this patient would have noticed those coughs. In fact, they probably should have stopped after that very first bolus because there was a small cough and not continued on to the second and third boluses. However, what I think is interesting to think about as we watch this video is that as speech-language pathologists, we tend to notice all sorts of other things in the course of watching this video. So when I play this to audiences of speech-language pathologists, I often receive comments about the little bit of barium that seems to be hanging on the lower lip of this patient, perhaps suggesting some sort of facial muscle weakness. I also receive comments about perceived effort in those swallows, particularly the second bolus, and thoughts about what that might mean in the video fluoroscopy. And thirdly, I sometimes receive comments about the voice quality, where there seems to be a little bit of increased roughness in the voice compared to some of the other phonation samples that speech-language pathologists are tuned to picking up in those samples. And I think a really interesting question is whether or not we're able to put ourselves genuinely in the shoes of that nurse and imagine whether these are things that they would notice, because we've been trained specifically to take note of these more subtle signs. Now, as we prepare to go on to the second case, I'd like you to take just a moment and think about what these clinical observations might mean in terms of what happened in the truth of that underlying video fluoroscopy. So remember that we saw coughs after the first bolus and certainly clearly after the third bolus. And some people think that they saw excess effort in the generation of those swallows. So I'd like you to take a note on a piece of paper about whether you think this person showed penetration or aspiration on any of those 3 boluses. And as a second question, I'd like you to make a note about whether you think this person had residue in their pharynx, either in the vallecula or in the piriform sinuses, after any of those boluses. And once we've gone through the second case, we'll reveal the truth to you about what the blinded rating of his video fluoroscopy said about what truly happened. So let's now move on to watching a second case. Here we have an older lady performing the swallowing task. And I'll just mention that you can see something taped to the front of her neck, just above the sternal notch. And that's an accelerometer device that we were using to collect vibrations of her swallowing during that particular study. So there we have the 3 non-swallowing tasks in this protocol performed by this lady, beginning with the tongue lateralization task. And here I imagine that you as a speech-language pathologist may have noticed that while she was moving her tongue from side to side, she displayed tremor in her facial musculature around her mouth, particularly on her left side. But that actually isn't one of the questions we ask of the nurse. We don't say, did you notice anything happening in their face while they were doing the task? We simply ask them, was she able to move her tongue from side to side? And I think that it is reasonable that a nurse would have concluded that she didn't have difficulty doing that task. Similarly, she produced voluntary cough. You might have heard things in that voluntary cough, but she was able to produce one. And when she came to producing the phonation task, I think she's probably one of the patients in our protocol who was slightly confused by the task of saying ha, 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 and she sort of chanted or sang it rather than speaking it in a normal speaking voice. But what we've asked the nurse to do is simply comment on whether the patient was able to do these 3 tasks without difficulty, and I think it's reasonable that a nurse answering that question would so far not have seen any signs of concern.
Ha ha ha!
So I'm going to stop the video here after that first thin swallow and make a couple of comments. First of all, to you as a speech-language pathologist, clearly this lady is having difficulty performing this task. There are in fact 10 swallows that we see in that sequence. And I think this is an interesting observation given that none of the screening tools that we've been talking about ask people to count how many swallows there are for a single bolus. This lady, I don't know what her diagnosis actually turned out to be. She wasn't a stroke patient, and so I imagine that she may be a person who had some sort of neurodegenerative condition. And certainly it's unusual to perform 10 swallows for a bolus, and we would hope that a nurse might have commented on that even though it wasn't asked. But strictly speaking, she hasn't failed the swallow screening protocol by displaying a higher number of swallows per bolus. You may also think that her voice was a little bit different after those swallows, and certainly some people hear something rough or wet in that voice sample right after the first bolus. And so I hope you're starting to imagine what the video fluoroscopic truth of that swallow might have looked like.
Hold on to it. Go ahead.
I think I'm done. Yeah. Ha 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 ha!
So here again on the second bolus we see a similar pattern in this patient with multiple swallows per bolus, apparent effort in completing the task, and you'll see at the end that she said, "I think I'm done," before she produced the ha 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 phonation task. The phonation task itself was in a quite clear voice, and so I'll ask you to make a note of your thoughts about what the video fluoroscopy might have looked like in this patient.
Go ahead.
Ha ha ha!
And so on this third bolus, we see things that we've seen before. This lady also wiped her lips at the beginning of the presentation, suggesting that she's aware of that little bit of bolus on her lower lip. We see multiple swallows for this bolus. We see facial grimacing as she's performing those swallows. I would argue that these are all things that we are tuned into as speech-language pathologists that a nurse may or may not have thought were worthy of comment. And then at the end, she produces the ha 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 with quite a clear voice quality. So given what we've seen, we have no really clear signs of airway invasion in this lady. She doesn't cough. Her voice quality remains reasonably clear after all three of those boluses. And the main thing that we're noticing is these multiple swallows per bolus that really aren't asked of the nurse as a question. So she might have reasonably passed this entire swallow screening protocol, both the non-swallowing tasks and the swallowing tasks, in an average screening situation. So let's now move on to reveal the truth behind these two cases. So here we have a table showing the results of the blinded rating of those video fluoroscopies that was performed in that research study. In the first case, we asked the speech-language pathologists to record a penetration aspiration scale score for each of those swallows, and scores of 3 and higher were considered abnormal. And then we also asked them to comment on whether they saw residue in either the vallecula or the piriform sinuses at the end of those swallows. And here we used a 4-point ordinal scale developed by Eisenhuber and colleagues that classifies residue severity based on how full the space appears. If there's no residue, there's a score of 0. If the space looks less than 25% full, there's a score of 1. If there's 25 to 50% filling of the space, they get a score of 2. And if the space appears to be more than 50% full, they get a score of 3. Now, if you think back to the first case, you'll remember that we had some coughing, and so I'm imagining that most of you thought he probably showed a penetration aspiration scale score of concern. And it turns out that, in fact, on those video fluoroscopy recordings, the penetration aspiration scale scores were 1, meaning no airway invasion, for each of those swallows. I do think that there's a possibility here that the video fluoroscopy image was turned off before those coughs happened. So it is possible that there was an airway invasion event that was missed on the video fluoroscopy that happened between bolus presentations. And that's an interesting limitation of video fluoroscopy when it's used as a reference test for a screening protocol, where we may actually miss the event of interest. And of course, similar limitations would exist with fees due to the whiteout that is seen during the middle of the swallow. However, you'll remember that we really didn't have a lot of concerns about the swallowing efficiency in this patient beyond the sort of subtle observation that perhaps he was using more effort than usual to produce those swallows. And yet, in all three cases, there was residue that was substantially filling the vallecula, between 25 and 50% full, and also filling the piriform sinuses on each swallow, that would classify his swallow as abnormal from an efficiency perspective. And we saw nothing in the screening protocol that would alert us to this possible underlying problem. Moving on to the second case of the lady with the multiple swallows per bolus, you'll remember that we said we didn't really see any overt signs of airway invasion, and her voice was largely clear on the post-swallow phonation tasks, and yet on every single one of those boluses, she displayed a penetration aspiration scale score of concern. On the first two, there was actual silent aspiration, getting a score of 8. And on the third bolus, there was a score of 4, where material went into the vestibule down as far as the vocal folds and was then ejected from that location. So she is a case of silent aspiration where the screening failed to pick up that concern. And as you'll remember, we really saw nothing obvious in her non-swallowing task behaviors or her swallowing task behaviors. Rather, given that we saw these multiple swallows per bolus, I think we were all expecting her to show considerable residue on those swallows. And in fact, her residue was reasonably mild, less than 25% full on that first bolus, which was a score that we did not classify as being a score of concern in our research project. And on the second and the third bolus, that increased to cross that threshold from normal to abnormal with 25 to 50% filling of both spaces. So I hope that this exercise is helpful for you to really confront the issue of what we don't see with our eyes during clinical screenings or clinical swallowing assessments, and also to challenge us about the validity of the signs that we do react to in those clinical bedside observations of patients that may not reveal the truth. To close out this section with the examples that we've just looked at, I want to briefly tell you about the results of the actual study where we had 40 individuals in whom we collected data. And what we did in that study, which is published in the article shown here on the slide, was we took those face video recordings and we played them to healthcare professional panels. So we had a panel of nurses who worked in an emergency room and were used to doing swallow screening, and we asked them individually to watch these videos and document their observations of whether there were any problems in the non-swallowing tasks and in the swallowing tasks. And we also asked that same question of a panel of speech-language pathologists who watched the videos. And one of the things that was really interesting that we hadn't thought to measure at the outset of the study was to note how these different professionals performed that task. So the nurses were very quick at doing the task. They sat down and they each individually watched each video once and had completed the task, and they had ratings for each patient. By contrast, the speech-language pathologists who participated in our study took much longer to document their clinical observations, and they watched each video multiple times, probably focusing in on subtle signs that really aren't being asked in a swallow screening situation. And I think this was a really interesting observation of how it's probably impossible for us as speech-language pathologists to take that summary screening approach where we're not focusing in on minute details that we've been trained to look for. We then took those ratings of the nurses and of the speech-language pathologists based on the face videos that you've seen, and we compared them to the video fluoroscopic truth, and we calculated sensitivity and specificity for each of those signs. So here I'll just share the results with you for the sensitivity and specificity to detecting or predicting that there had been an airway invasion event during the video fluoroscopy. And again, our threshold of concern here would have been a penetration aspiration scale score of 3 or worse. And you can see at the top the performance of the SLP ratings based on those videos. You can see that the tongue lateralization task was very poor from a sensitivity perspective and modest from a specificity point of view. The detection of an abnormal baseline cough was slightly better, but still really inadequate from a sensitivity point of view, and its specificity again was modest. The observation of abnormal baseline voice quality was pretty well at chance at 54% sensitivity, and again, modest specificity. And the one sign that I think we would think would be most informative, that is the post-swallow cough or throat clear or change in voice, again had unacceptably low sensitivity and worse specificity than the other 3 signs. We also included a question about whether there were any other signs of concern picked up in the screen that would prompt a speech-language pathologist, in this case, to fail the patient on the swallow screening. And you can see that that also had poor sensitivity and modest specificity. When we looked at the overall result, the sensitivity was better than any one of the individual signs at 73%, but that's still below the 80% target that is generally considered to be minimally acceptable sensitivity on a screen. And the specificity was really poor, suggesting that here what we have is a situation of over-identification of problems in the swallow screen versus the video fluoroscopic truth. When it came to the nurses, the results are really relatively similar. I won't go through each one in detail. The observations of post-swallow cough, throat clear, or voice change here were actually better in the nurses than in the speech-language pathologists, but still well below the 80% target for sensitivity. And overall, the results of the nurses were worse for sensitivity than they were in the speech-language pathologists, and really unacceptably low. And the specificity was also low. So here we have really, I think, a challenge. This is, to my knowledge, one of the few studies where the truth, the reference test, was from exactly the same swallows as those observed during the screen. There are clearly some possible issues with the fact that people were watching videos rather than interacting directly with the patients. And we limited our swallowing tasks here to teaspoon volumes of thin liquid rather than involving a large volume challenge. And those teaspoon volumes may be inadequate to challenge the system sufficiently to reveal a problem, but we definitely have issues here with poor sensitivity of this screening test and a trend towards over-identification reflected in the poor specificity values. So before we conclude, I want to share results from one other study with you. That is a study that I was the principal investigator on. This was actually a study that was looking at the development of a device for screening, where we hoped to be able to train a device to accurately detect penetration or aspiration or residue based on a series of swallows where we collected simultaneous video fluoroscopic information. So this wasn't specifically a screening validation test, rather a device training test, and the results of that study were published in the Dysphagia Journal in January of 2019. I will let you know that at the moment further development of this device is on hold because in a subsequent study the algorithms that were trained did not perform as well as we had hoped. So for the original study, however, which we called the SONAR study and which was funded by Nestle Health Science, we collected a large amount of data across 7 hospitals in the United States from a total of 332 adults who were considered reasonable to do a video fluoroscopy in because of questions of dysphagia risk. So again, the sample may be slightly skewed given that we didn't recruit completely healthy, normal people to balance out those with possible dysphagia. You can see here that we did not include in the study people with known congenital abnormalities, with a history of head and neck surgery, or a history of radiation to the head and neck. And you can see that we had a mean age in this sample of adults of 70 years old with a range from 59 to 81. And about 1/3 of this sample were people who had an etiology of stroke, a small additional number of brain injury, and then the remainder had other diagnoses. So here you can see the protocol that was used in that study, which began with 6 sips. These were natural sips in a non-cued swallow paradigm of thin liquid barium, and then we also continued to have these participants swallow 3 boluses each of mildly, moderately, and extremely thick barium, where what we did was we thickened the thin barium with a xanthan gum thickener. And the issue I want to actually illustrate from this study is from the thin liquid swallows that we collected. So here you can see that in total we had 1,730 thin boluses in our data set collected from 305 participants. So there were a few where the data couldn't be analyzed completely. You can also see the link to the manuscript there on the slide, and it is available open access. So when we looked at penetration and aspiration, and we're looking for scores of 3 or higher on those boluses, you can see that in total, out of those 1,730 boluses, we observed problems through our rigorous blinded rating procedure on 125 of them. So 7% or so overall, a rate of penetration and aspiration of concern at the bolus level. You can also see on the right-hand side of the screen, though, that we have this phenomenon where those 125 boluses came from 79 people. So what we don't have here are people who were penetrating or aspirating multiple times on every bolus presentation. About half of those 79 people probably had 2 episodes of penetration or aspiration of concern, and the remainder only showed 1 across the boluses that were presented. So at the participant level, we had 26% showing a problem, but only on 7% of the available boluses. So we thought this was interesting, and we thought it was worth digging into the detail of performance across the repeated thin boluses that were presented to see how often people differed on the different boluses in their penetration aspiration scale scores. So you can see here that on the first bolus presentation, 8% of the patients in our sample showed a sign of concern. And then on the second bolus, we've shaded those 8% so that we don't double count them. But the total number of people who had shown a problem by the end of bolus number 2 was 15%. So there were 7% of the sample who were fine on bolus number 1, but then showed a problem on bolus number 2. On bolus number 3, the number grows to 18%. And then on the fourth bolus, the number grows to 22%. And then it sort of hovers in the low 20s across the 5th and 6th boluses. What these data very clearly say to us are that if you only sample 1 bolus, that's not an adequate sample to confirm whether or not your patient has a problem with airway invasion. And in these data, we didn't go out beyond 6 boluses of thin liquid, so we can't say for sure what would have happened with 7, 8, 9, 10. But based on the trends in these data, we think that if you're wanting to rule out penetration or aspiration in your patient, that you probably need to sample 4 boluses. And this, I think, speaks both to the design of screening protocols in terms of the tasks that might be included. And if you're doing single SIPs, this would suggest that you need to collect 4. And this also has implications for our clinical bedside swallowing assessments as speech-language pathologists, and indeed for our instrumental exams, to ensure that we adequately sample behavior to be certain that we haven't missed an issue of concern. So before we conclude, I just want to briefly take a detour to discuss 2 other approaches to screening that are described in the literature and where I sometimes get questions about whether or not these are additional helpful components for a screen or useful alternatives. And as shown on the slide, those 2 adjuncts are pulse oximetry and cough reflex testing. So starting with pulse oximetry first, I'll just mention that there are screening protocols, including the volume viscosity swallowing test that we've talked about so far, where the designers of the test have included pulse oximetry as one of the things that becomes monitored by the person doing the screening. But you may know that the utility of pulse oximetry for detecting events of concern in swallowing is really very controversial in the literature, and probably about half of the studies out there suggest that it might carry some useful information and the other half say it doesn't. I've shown here one of the more recent papers on this question out of a group in Germany, and these authors concluded that oxygen saturation is not useful for detecting penetration or aspiration in stroke patients. And really, I think this is a carefully performed study and really the most appropriate conclusion to draw from the available literature. I do think, however, that expanding our focus from watching signs of swallowing per se to also consider signs related to respiration and coughing in our patients is interesting, and I commend to you this excellent review article about the framework of the systems that go into swallowing and airway protection from Michelle Troche's group. So one way to evaluate the integrity of a person's cough is to perform cough reflex testing. And the conventional way to perform cough reflex testing involves using a nebulizer and administering different concentrations of an irritant stimulus such as tartaric acid or citric acid or perhaps capsaicin, and observing whether or not the person coughs. And these tests are designed in such a way that healthy people would be expected to cough. And the idea of using cough reflex testing to tell us something about swallowing has actually been around for quite a long time, and it was controversial when it was first introduced because, of course, the absence of a cough in this test, which might tell us something about whether a person is likely to cough when they aspirate, doesn't tell us anything about the rest of the swallowing mechanism. So in the years since that idea was first introduced, several groups have done quite a lot of work on cough reflex testing. That includes the group from University of Florida, where Michelle Troche was, with her colleague Karen Wheeler-Hegland, and also the group in New Zealand, led by Dr. Maggie Lee Huckabee, have been using cough reflex testing in their research. And on this slide, I'm showing one recent article from the New Zealand group, led here by Dr. Anna Miles, and they did something really quite interesting in this study. They weren't using cough reflex testing to try to determine whether or not somebody was aspirating, but in people who were referred for a swallowing assessment, they used cough reflex testing to see if they could get a non-invasive prediction of whether aspiration was silent. And in their work, they have incorporated cough reflex testing into the care pathway for stroke patients with suspected dysphagia in many hospitals. So in this particular study, Dr. Miles and colleagues describe a project that took place in 2 hospitals. In the first hospital, 101 patients who were referred for FEES investigation of swallowing took part in the study. And in the second hospital, 80 patients who were referred for video fluoroscopy took part in the study. And in both hospitals, a cough reflex test was performed within 1 hour, either before or after the instrumental exam. And in that test, they used different concentrations of citric acid. They also had a placebo condition, and they administered 3 trials of each concentration, and a person would pass the cough reflex test at a given concentration if a cough was elicited on 2 of those 3 trials. So in the article, Miles and colleagues give quite detailed breakdown of the results, and for the sake of today's presentation, I've summarized them here on this slide. So we can see that for the cough reflex tests, about 23 to 25% of the participants in both hospitals failed this test, meaning that they did not produce 2 coughs at any of the concentrations that were tested, right up to 0.8 moles per liter. And then below you can see the corresponding results for the FEES and the video fluoroscopy. So you can see that the results are quite different here, depending on the examination that was performed, and that suggests that the patient populations might have been different. So for those who were referred for a FEES exam, we have 38% who showed no signs of aspiration on that FEES exam. And then we have quite a large number, all told, who did aspirate, 27% who aspirated and then produced a cough, and 36% who aspirated and had no overt signs, so silent aspiration. So it's these 36% where it's particularly interesting to understand what their cough reflex tests looked like. In the second hospital where the video fluoroscopies were the instrumental assessment, here we have 70% of the people undergoing video fluoroscopy who showed no aspiration, and then 30% who did aspirate, and of those, almost 2/3, the 21% of the total number, had silent aspiration. And here on this slide, we then see the results in terms of sensitivity and specificity from each of those hospitals. So in the hospital where FEES was the instrumental examination, Miles and colleagues found that the best performance of the screening test was obtained at 0.4 moles per liter, so the lowest of the three concentrations that they tested. And at that concentration, there was a sensitivity of 69% and a specificity of 71% for silent aspiration. Now, like the previous studies that we've talked about, these numbers are likely summarized at the patient level, and the sensitivity is really below what we consider a usual accepted target. But it's quite interesting that they achieved this with such a narrow focus on catching only one level on that penetration aspiration scale of true silent aspiration. In the video fluoroscopy group, we see really quite similar results, although here in this particular study cohort, the performance of the cough reflex test was better at the 0.6 mole per liter concentration. And when Miles and colleagues put all of the data together and looked at the odds of silent aspiration depending on passing or failing the cough reflex test, they found that the strongest predictor of silent aspiration was failure of a cough reflex test at the highest concentration that they tested, which makes sense, of 0.8 moles per liter. And when you failed the test at that concentration and you were in the FEES component of the study, then the risk of silent aspiration was 7-fold higher than if you passed the test, and for video fluoroscopy, it was 8-fold higher. So certainly cough reflex testing appears to have some interesting value in terms of our ability to understand whether aspiration might be silent in our patients. And I think as an adjunct to clinical bedside swallowing assessment, it's something very interesting to consider. I want to say that my personal understanding of cough reflex testing is that it's not a really simple procedure and it does require training, but it may be something to consider if you're in a facility where it is difficult to access instrumental assessments in a timely manner. So that brings me to the conclusion of this webinar, exploring doubts and challenges regarding the topic of swallow screening. I hope that you found it helpful to work through these issues and to listen to me express my own doubts. And I'm happy to receive questions regarding this webinar content at the email shown on this slide. I also encourage you to follow our lab either at our Twitter handle or on our lab Facebook page. And I wish you all the best in your practice.